Hi everyone, this is Stacy Snyder, and today we will be talking about a laryngenectomy. So many of you may be wondering, what is a laryngenectomy? A laryngenectomy is the removal of the larynx and can be performed as a hemilaryngenectomy, which is where only half of the larynx is removed, a partial laryngenectomy, which is where only portion of the larynx is removed, or a total laryngenectomy, which is where the entire larynx is removed. The larynx houses the vocal cords, and it's also known as the voice box. The larynx extends from the superior surface of the epiglottis to the coriacod cartilage. The larynx provides a passageway for gases to get into and out of the lungs. The larynx contains single structures of cartilage and also paired cartilages. The single structures are the epiglottic cartilage, thyroid cartilage, and the coriacod cartilage. The paired cartilages of the larynx are the cuneiform cartilage, the corniculate cartilage, and the arytenoid cartilage. The epiglottic cartilage is the only cartilage of the larynx that is elastic. It is attached to the upper border of the thyroid cartilage, which helps support the flap-like structure called the epiglottis, which helps close the larynx when swallowing. The thyroid cartilage is named after the thyroid gland. It is a shield-like structure located in the neck. It's also known as the Adam's apple. It's more commonly seen in males due to sex hormones. The coriacod cartilage lies inferior to the thyroid cartilage and marks the lowest area of the larynx. The cuneiform cartilage is a small cylindrical shaped structure that is located between the epiglottic cartilage and the arytenoid cartilage. The corniculate cartilage is a cone-shaped structure that is attached to the tips of the arytenoid cartilage. Muscles attach here to help regulate the tension that is applied onto the vocal cords and to help with closing of the epiglottis during swallowing. The arytenoid cartilage is a pyramid-shaped structure that lies just above the coriacod cartilage. A laryngenectomy is normally performed when a patient has cancer of the larynx, or in some cases, when a patient undergoes radiation therapy, they may get necrosis of the larynx, and a laryngenectomy may be performed to treat that as well. When applying the skin prep solution to the patient, a towel should first be placed underneath the patient. This towel will help prevent pooling from occurring underneath the patient, and this will also help prevent chemical burns from occurring to the patient's skin. After the solution has been applied to the patient, the towel should be removed from underneath the patient. When applying the skin prep solution, it is applied in a circular motion, and this should be started at the anterior neck, which is where the surgical site would be. And the area will extend from the lower lip to the axilla area, which is where the armpit is. And this includes the sides of the neck, extending down to the operating room table. Remember, when applying the skin prep solution, once you go down, do not go back up. If for any reason you need to go back up, get a new skin prep applicator to apply the skin prep solution. The patient is placed in the supine position with the arms extended out on padded arm boards, or their arms are tucked in at their sides. The patient's neck is also hyperextended, and that can be done using a donut-like headrest. And when positioning the patient, all bony prominences should be padded, and they can be padded using towels, blankets, sheets, pillows, or even jelly rolls. For example, a pillow or some kind of padding should be placed under the patient's knees, which will help reduce strain on the patient's lower back for this procedure. The patient is given general anesthesia for this type of procedure while in the supine position. When draping the patient, 4 folded sterile towels should be placed around the surgical site. Then a fenestrated drape is placed with the opening of the drape exposing the surgical site. And in the case that the fenestrated drape does not cover the patient's feet or the end of the operating table, then a 3/4 drape can be used to drape the feet and the end of the operating room table. So some of the equipment and supplies that may be required for this procedure would be items such as a foam or jelly, donut-like headrest, folded towels or sheets to help extend the neck, a compression device, a forced air warming blanket, a fiber optic headlight with the light source, and that's only if the surgeon would want it. That's not something that has to be used for the procedure. Drapes, marking pen, a basin set, blades, preferably blades number 10 and number 15, a needle magnet or a foam counter or both, a scratch pad for an ESU and an ESU holster, suction tubing, dissectors such as Kittners or Peanuts, umbilical tape, open-ended catheters, those would need to be flexible, tracheostomy tubes, and closed suction drains such as a Hemovac or a Jackson Pratt drain. Some of the instruments that may be required to successfully perform this procedure would be a basic minor tray, a tracheostomy tray, a thyroid tray, a small Yankauer suction tip, fine pointed right angle clamps may be needed. It might even be wise to have a couple extra of those just in case those are needed, and also a retractor set. Okay, so the procedure for a laryngenectomy starts with an apron-like incision that will be made using a 15 blade. The incision is made from the mid-sternocleidomastoid mastoid muscle to the mid-sternocleidomastoid mastoid muscle. The flaps are elevated to about 1 inch above the sternal notch and about 1 inch below the hyoid bone. And these flaps can be retracted using skin hooks or they can be sutured back. The ESU or Mayo scissors are used to dissect the strap muscle from the sternum. An Army, Navy, or even a Goulet retractor can be used to expose the carotid sheath, the thyroid, and part of the upper portion of the trachea. The carotid sheath is dissected laterally using blunt dissection, exposing the common carotid artery, the internal jugular vein, the vagus nerve, the deep cervical lymph nodes, and then they are retracted using a vein retractor. The thyroid veins are ligated using a hemostat and 2O silk ties. The thyroid lobe is then removed by dissecting the part that needs to be removed using scissors or a bovie, and this is done until it has been dissected. Any fat or lymph tissue that is encountered, then that is removed using scissors or a bovie. The inferior thyroid artery and the recurrent laryngeal nerve is transected using scissors or a bovie. Blunt dissection will now occur using hemostats, Kittners, sponges, or even the surgeon's finger. The thyroid is then grasped using a coker, and the bovie is used to completely remove the thyroid from the trachea. The larynx is rotated to allow exposure of the constrictor muscles on the thyroid cartilage. Then it is dissected using the bovie. Soft tissue on the underside of the thyroid cartilage is removed using an elevator. The larynx is then rotated in the opposite direction to remove the remainder of the soft tissue that is on the thyroid cartilage. The thyroid cartilage is removed from the hyoid bone by using hemostats or Metzenbaum scissors. Heavy Mayo scissors are used to remove pieces of the hyoid bone, and then the surgeon is ready to perform the tracheotomy because the surgeon is about to enter the airway. The anterior part of the tracheal wall is stitched to the posterior skin flap and secured into place. The anesthesia tube is now removed and switched to the tracheotomy tube. An incision is made in the middle of the hypopharynx over the hyoid bone using a blade, an ESU, or scissors. A hemostat is used to open the hypopharynx to expose the epiglottis. The epiglottis is grasped with an Alice clamp, and it is pulled out and rotated out of the larynx. The lateral pharyngeal walls are incised using scissors or a bovie to open the larynx. The tracheal tube is removed and a 15 blade is used to incise the posterior trachea. The anterior esophageal wall is dissected from the trachea using scissors along with any fibrous attachments, allowing the larynx to be removed. The tracheal tube is replaced, and then the pharyngeal mucosa is closed in 2 layers. Both layers are closed with absorbable suture sized 3/0 or surgeon preference. A stoma is created by closing the anterior tracheal wall to the inferior skin flap and the posterior tracheal wall to the superior skin flap. These are closed using absorbable or non-absorbable suture, whichever the surgeon prefers. And then the wound is irrigated with saline. The drains are placed and the skin is closed in layers using absorbable suture. Dressings would consist of either Zeroform or Dermabond with 4x4s and a Tegaderm. The laryngenectomy wound is considered a clean wound.
I pirouette in the dark. I see the stars through